Hi, listeners.
Hello. Welcome to the MedInsights Unleashed podcast
With your hosts,
Z
and John.
Hi, John. How's it going?
Sarah, I've been overcome with podcasts.
I know. It's been a busy time, which is good.
Yeah,
It's a good problem to have, right?
we've got them in a queue now, which is amazing. And with our speakers that we've had attending are just brilliant, absolutely brilliant. And we've covered everything from orthopedics to pancreatic cancer and palliative care in the space of a week. So it's been an amazing triumph for getting the messages out for all these doctors. And we have got a spectacular doctor with us today
No. Yes.
that I'll let you introduce, but really dynamic. And we just really want to do the best we can for all the research that she's done and make sure that people get to know about this particular groundbreaking phase 3 trial.
John, do you want to carry on? You've done such a great introduction.
No.
No, thanks. No, we have Dr. Sharlene Gill in the virtual studio. And I've known Sharlene for a really long time, both on a professional and a personal level. So I'm honored that she agreed to be a guest on our podcast. And exercise is something that I live by. I know Sharlene does. John, I know it's so part of your lifestyle as well. I'll let Sharlene, introduce herself. But the discussion we're having today is around the study called the Challenge Study, again, brilliant name, that was recently presented at ASCO. And so it's about the benefit of exercise post-surgical treatment of patients with colon cancer, adjuvant colon cancer. So Sharlene, I'm going to turn it over to you just to introduce yourself. And again, thank you for being a guest on our podcast, and over to you.
Thank you so much, Zara and John, for the invitation. I commented to you earlier that I've been following your podcast, and I've been like, when is Zara going to invite me? So I'm very happy to be joining you today. So I'm a GI medical oncologist based out of BC Cancer in Vancouver, BC, and I'm a professor of medicine at the University of British Columbia. And I'm also fortunate to wear the hat of chairing the GI disease site committee for the CCTG, the Canadian Cancer Trials Group, which conducted the study we're talking about.
Challenge Study, absolutely brilliant name, because exercise is challenging. So do you want to maybe provide some context behind the study and just kind of walk us through how you guys got to starting the study and then,
Sure, yeah. This study was conceived like about 18 years ago. And it was in an environment where there was increasing epidemiologic data that patients who after colon cancer treatment who exercised as reported on surveys or, retrospectively assessed, that seemed to be associated with a better outcome. And the signal was consistent. It was always like, it was never that exercise was worse for you. It was like people seemed to do better. The hard part with any observational study or retrospective study is that it's not controlled, right? So the criticism for epidemiologic data has always been, yes, but people who choose to exercise are different. And there may be something biologically different about them. And so how do we know that it's actually, is it confounded by something else, or is it actually the exercise?
Right.
And so Dr. Chris Booth, who is now a medical oncologist and professor at Kingston University, he was a fellow within the CCTG program. And so he came to us with this idea of, I'd like to do a study on exercise. And, this is in an environment where no one was trying to do a randomized study of exercise. It just seemed like the name challenge wasn't by accident. It was like, this is going to be hard. But we're fortunate in Canada. We have a lot of amazing physical activity expertise. And so Dr. Carrie Cornea, who is a chair in sort of exercise science in cancer now, but at the time was kind of one of the leading kinesiologists, and who's based in Edmonton at the University of Alberta, came on board to kind of help, put this idea into like some study design, like what would that look like? And what he emphasized, and I think what we all realized, was that this wasn't just about exercise. The study is a structured exercise program. And so it involves not just telling people to exercise, but some behavioral change support and some psychology around that to drive that change. And so that's kind of, the environment in which it was conceived. The Canadian Cancer Trials Group is funded by the Canadian Cancer Society. So this came through philanthropic funding and some public funding. There was grant support along the way that helped support enabling participation from other countries like Australia and then subsequently the UK. But this was very much a cooperative group, like a question that no one else is going to ask. So it was an academic cooperative group study. So that was, the genesis of it many years ago. And we decided to set the bar high. It wasn't, we do obviously hope these improve patients' quality of life, but the bar was to say, can we demonstrate that this improves survival? And the reason we felt
that was your primary objective.
that was the primary endpoint was disease-free survival, and the secondary endpoint was overall survival. And the motivation behind that was also driven by the reality that in publicly funded systems like ours in Canada, like Australia, like the UK, we felt that we needed to demonstrate that level of evidence, sort of that level 1 evidence, to be able to advocate for funding to support structured exercise programs for patients who've completed their adjuvant treatment for colon cancer and are now transitioning to surveillance.
It's an amazing study, and congratulations, because New England Journal is exceedingly very, very hard to get published. This is the first study, randomized phase 3 trial ever to show an advantage,
Yeah.
a
Yeah.
survival advantage in
In
patients.
any cancer,
It's
yeah.
in
Yeah,
any
it is.
cancer.
Yeah, it is the first randomized control trial to show in any cancer that exercise improves survival. And so we were very grateful to be able to, as a group, have a simultaneous New England Journal publication with the ASCO presentation. And again, full credit to the CCTG leadership for being brave enough to stick their neck out and say, yeah, we're going to support this trial. And obviously to Chris Booth and Carrie Cornea, who really championed this study, for the past, 17 years. It was 15 years of accrual. As I mentioned, Dr. Booth, who's now a full professor at Kingston and was a fellow when he started,
Right.
he was like, this is like raising a child. But we're just deeply gratified that the results have demonstrated that this is a standard of care change in terms of how we practice, and hopefully will kind of really propel this shift to really thinking about exercise as not just something that, oh, it feels good and we should tell people and why not, but really something that needs to be embedded in our care delivery, like as a standard of care.
There should have been a plenary at ASCO.
Don't get me started.
Well, let's get into the results then, Charlene. And you can talk about the patient population and the control versus the active exercise group.
So I mentioned earlier this was a phase 3 trial, and I think most of your audience is familiar with what that means. But this is a randomized control trial where patients with high-risk stage 2 and stage 3 colon cancer who have completed adjuvant chemotherapy. So they had surgery, they completed their chemotherapy, which was typically 5-FU-based chemotherapy, so either a combination with oxaliplatin or capecitabine alone. And then within 2 to 6 months of them completing their adjuvant treatment, they were registered for enrollment in the study and initially had a baseline fitness test. And that test was to ensure, A, that patients could complete the intervention of structured exercise, and B, make sure that they're not already so active that, you're not going to see much incremental improvement. Like the folks who are already, running 10K twice a week, those are not the folks where you're going to be able to demonstrate this, whether exercise is going to improve outcomes. And then patients were randomized 1-to-1 to either receive standard of care surveillance plus educational materials The control arm received basically a booklet that talked about the benefits of exercise based on observational data, and we think this is good for you. So it included sort of an extra component of health education materials. And the experimental arm included the surveillance and the health education materials, but also a enrollment in a structured exercise program. And I'm happy to go into kind of what that looked like because
I
I
think
do,
you should for the
yeah,
audience. Yeah.
because I do think it's important for your listeners to understand, like, this is not like a getting hooked up with a personal trainer every day.
Right.
It was a 3-year program split into 3 phases. And so the first phase, which was the first 6 months after enrollment, patients were asked to participate, like what was we called the mandated sessions, every 2 weeks for an in-person session with a supervised physical activity consultant and with a behavior support counselor. And sometimes those things were happening at the same time, meaning patients were like in the gym working out and someone was actually talking to them about lifestyle change. And it was a very structured program, meaning Kerry Cornea and his team had developed like almost a script, a very prescriptive approach to how patients were going to be supervised, which is really important, because you want this to be consistently applied as an intervention. And the goal in the first 6 months was to try to increase a patient's level of activity by 10 MET hours per week. So a MET hour is like 1 MET is a unit of energy. So it's like if I'm just sitting here, for an hour, I may expend 1 MET. 1 hour of brisk walking expends 4 MET, 4 MET hours. The example that's often been used was to increase someone's physical activity by 10 MET hours per week from their current baseline. It would be an additional 2.5 hours of brisk walking per week, as an example. And brisk walking is not a stroll. Brisk walking is like walking with intention. And Dr. Cornea has described it as if someone saw you walking, they'd be like, wow, Charlene's in a rush to get somewhere, like you are walking. So that was the first 6 months. So basically 12 sessions in total every 2 weeks. Patients were also encouraged beyond to attend an additional, like an alternating weeks to also come in for a session. And so but that wasn't a mandatory component.
Okay.
And then in the second phase, which was months 6 to 12, those mandatory sessions continued, but now there was an option of virtual that was incorporated. And we can talk a little bit about the silver lining of COVID, but that virtual program really has become an important piece in thinking about implementation and equity and, geographic disparity. But it kind of continued every 2 weeks for another 12 sessions. And then the sort of sustainment phase, I guess, years 2 and 3, patients were mandated to come in monthly for an in-person or to attend a virtual supervised physical activity assessment. And over the course of this, like their baseline fitness assessment included things like the VO2 max, like trying to look at fitness indices that could be followed over time, and a number of correlative studies that have not yet been, reported or completed or planned in terms of blood plasma collection, trying to, understand more about the science of exercise in this setting. But that was it. It was a 3-year program. More than 2/3 of patients, like 65% of patients, completed all mandated sessions.
That's incredible.
Very
That's
high.
great. And especially over 3 years.
Especially, yes. So that was, I mean, and I think it kind of
Crazy.
spoke to, the fact that, like, this resonates with people, right? I mean, there was an earlier publication on the feasibility of this, like while the trial was accruing, which is reporting this really encouraging adherence and compliance to the study protocol. One of the challenges, pardon the pun, was though that it took time to on-ramp sites, to create the infrastructure at each center, to be able to deliver the physical activity component. So, for example, at our center at BC Cancer in Vancouver, we partnered with Kristen Campbell, who's a kinesiologist at the University of British Columbia, and she led the exercise delivery component, for our patients. So each center had to figure that out. And in total, almost 900 patients with 889
Yeah.
patients were randomized over, what was like a 15-year period. So it took time to enroll these patients. And the only side effect that was reported was musculoskeletal. So the only, which I think we'll use kind of the language of it's an on-target effect. So more patients in the exercise group reported sort of musculoskeletal, like muscle fatigue and things like that.
Charlene, thanks for walking us through the setup and, you know, framing the entire context. We haven't yet talked about the final, like the beneficial results. So did you want to share that before I go further into
Yeah, I would. I
Dawn
could
and I?
talk about it. I could talk about it all day. So, I mean, that is, at the end of the
Uh-oh.
day, we're talking about this because the challenge study did demonstrate that patients randomly assigned to a structured exercise program versus health education materials alone did accrue benefit both in terms of their disease-free survival as well as the secondary endpoint of overall survival. So for disease-free survival, there was almost a 28% proportional reduction in risk of cancer recurrence over time. Because of that long accrual, the median follow-up was also quite long. And so at 5 years, the disease-free survival in absolute terms had improved by about 6.5%. And if we think about that in kind of the number needed to treat framework, which we use a lot sometimes in trying to think about value of an intervention, for every 16 people who exercised, one person was prevented from having a recurrence or a new cancer. Right?
Wow.
So we say it's an NNT of 1 in 16, which is really powerful if we think about a lot of interventions where you'd have to treat many more people to see that benefit.
I was looking at the Kaplan-Meier curve, and that's one of the things that you should talk about. But what really amazed me in the disease-free survival group was the curve split really early.
Yeah.
It was quite an amazing thing to see. I would never have expected that.
Yeah, they split early and it was sustained over time. It wasn't
Yeah.
like curves going back and forth or crossing each other. And I agree with you that, as a geek, Kaplan-Meier curves, like they really tell a good story about
Mhm.
kind of that in that time to event analysis, the trajectory and the timing of how things are happening. So in this case, you're right. They separated and they stayed separated. And in fact, that separation got bigger over time, partly because the benefit that was seen was not just in reduction in new cancers, but also, in recurrent colon cancers, but also a reduction in new cancers. And so while there's still small numbers in absolute terms, so it's not like it's hard to interrogate it statistically, the main driver for that improved DFS was reduced colon cancer recurrence, and a lot of that was reduced recurrence in the liver. But what was also observed was on almost like a halving of the risk of new primaries like breast and prostate cancer, which in this older population, that they are, eh, these are also like sort of in the top three, and that these patients are at risk for. So that really kind of has raised a lot of questions about, that if we think about, why exercise should improve outcomes for people with cancer, the science has always been around kind of like three big things. So one is that exercise reduces that inflammatory environment, so that
Mhm.
inflammatory milieu and pro-inflammatory cytokines are carcinogenic. We always talk about kind of reducing inflammation. The second is that exercise reduces levels of sex hormones, so like estrogen, progesterone. And is it possible that those reductions in breast and prostate cancer that were observed as potential like second new primaries in this population are driven by that? It's interesting. And the third is that, there's been sort of a lot of science around insulin and insulin-like growth factors, like in terms of metabolic regulation and the role that they have as pro-carcinogenic and promoting cancer growth. And so IGF-1 is commonly cited. So there is a biologic rationale for why exercise should be beneficial. And then to see that actually translated in a randomized control trial is again very, gratifying. Yeah.
So congratulations again. And thank you, because that was one of my questions was, what's the biologic component? But you've answered that really well. So I'm going to move on to my next question. And that's around the generalizability of the trial patients of the patients within this trial.
Yeah.
the trial excluded patients that had early recurrence or aggressive patients, right? So if you're going to take this trial and say, let's try to apply it to the broader patient population, what are your thoughts around that?
Yeah, I think generalizability is is the question we ask ourselves when, when we see a positive trial and say, okay, yeah, in this very careful environment of a clinical trial, you're able to show it, but how will this land in real life? That period of waiting 2 to 6 months after completion of adjuvant therapy was partly to make sure that there weren't patients who had already recurred in that time window. So they required restaging when at the time they're having their functional assessment done, because that is a different biology of disease. And I would not hesitate to offer someone with like stage 3C colon cancer. Those patients were included in the trial. We just made sure that they were restaged after adjuvant chemotherapy, given a few months to make sure that they weren't like early recurrences.
Sorry, Charlene, can you explain a stage 3, stage C
Stage three.
patient?
Oh yeah, yes.
3C, because
So yeah, so when we think about staging for colon cancer, yeah, so we think about patients who are eligible for adjuvant chemotherapy are typically those patients who are at higher risk for recurrence. So that's a subset of patients with lymph node negative colon cancer, so stage 2, and pretty much all patients with stage 3, which is lymph node positive cancer. And then within stage 3, and if this podcast is aired 6 months later, this might change because
Oh,
the
well,
AJCC is revising the criteria. Within stage 3, there's an ABC because like that's still a heterogeneous group of people. Like you can have one lymph node positive, or you can have like 8 lymph nodes positive. So stage 3C are those patients who have either like T4, so like disease that's grown right through the wall and invading and stuck into an adjacent organ, primaries with lymph node positivity, or more than 4 lymph nodes, so like 5 or 6 or 7 lymph nodes. And so we know that's a higher risk population. But those patients they were not excluded. Stage 3 was not excluded from the trial. You just had to have not recurred by the time you got enrolled in the study. And like I said, there was that 2 to 6 month interval. On average, patients were enrolled by month 4.
okay.
perfect.
But we haven't even talked about the survival data.
Well, that's true. We talked about the disease-free
We
survival.
talked about the disease-free survival.
Yes.
And even though overall survival was a secondary endpoint, I think at the end of the day, when you talk to patients about an intervention, they want to know, is it going to help me live longer and help me live better, right? So the secondary endpoint of overall survival was also met, thankfully. Hazard ratio of 0.63, which translates into a 37% proportional reduction in risk of death over time. And with the longer follow-up, like at 8 years, that improvement in overall survival was like 7%. And those curves they are together and then they start to split up later because
Right.
obviously recurrences happen earlier, and then, the event of dying of a cancer happens later.
But
If
it's
we
still quick. It's at around 60 to 70 month period that the curve split, which
Yeah.
is quite incredible.
Yeah. And so the number needed to treat for that delta was 14. So 14 people exercising in a structured exercise program. I want to make sure I use my language carefully here. Prevented, one person from dying. And again, those deaths were primarily driven by a reduction in colon cancer deaths.
So from that, thank you. You've helped me structure my next question, because this was a structured exercise. Patients that had a structured exercise program gained the most benefit. So the question I have is, what are your thoughts around the benefit of physical therapy versus, do you think that having the behavioral support and that human connection further enhanced the benefit that was seen? And
Yeah.
then part two of that would be, how can we then, or how can you then translate this into implementation of such structured physical programs into everyday?
The behavioral science piece is so important. Like you ask an average person on the street, everyone knows exercise is good for you. Like no one says, "Oh, that's bad for me," right? So, but not everyone is able to incorporate that as part of their lifestyle. And
Mhm.
so, on the one hand, we could just say, "Well, we told them we've said, we think exercise is a good idea, and then it's your personal responsibility. And if you do, you do, you don't, you don't. Or we could enable them. And I think what a trial like this demonstrates, especially with that adherence that we talked about, that 2/3 of patients stuck with it for the 3 years, right? Is that you can change behavior. People do want to be able to adopt, exercise into their lifestyle. Sometimes they don't know how. Sometimes they think it's too complicated. Sometimes they think it's an expensive gym that will, you have to spend all this money to do exercise. And in medicine, this example has been seen in other disease settings. So we know that, patients have a cardiac event. Exercise is an important part of their rehabilitation. So the system provides cardiac rehab for patients after a cardiac event. We know that in diabetes management, metabolic dysfunction, increasingly more and more diabetes clinics and programs will offer support for exercise. So, I mean, it's not rocket science. It's not rocket science. Yeah. New England Journal of Medicine worthy, but it's actually not rocket science. And so right now in the conversations I have with patients in clinic, I use the data to say, look, this isn't just we think it might be a good idea. This is,
Fact.
For every 14 people who exercise, one person is not going to die of their colon cancer. And that's powerful. The strength of the evidence is powerful for patients. I send a letter to their primary care provider just asking for some ongoing kind of follow-up. We'll talk about, education and ideally what we're working towards in our province. And I think we're hoping this will happen across Canada is implementation of a program where I can write a prescription and refer a patient to an exercise program that can be delivered to them regardless of where they live or their financial capacity or socioeconomic status. And it's so much more cost effective than so many things we do in oncology today, let alone, and we're hoping this is what subsequent analyses will show, are the quality of life benefits, the mental health benefits, all of those other things that we know go along with exercise. I think what's different is that we don't know how to implement this in oncology. Like we know how to implement a new treatment, a drug treatment, but this is a different paradigm.
And it's different, it's challenging because I think the payers are going to be big. Orthopedic surgeons can write a script for physiotherapy 6 weeks or whatever. Are you saying that this is a problem from a medical oncology perspective?
Yeah. So physiotherapy is not publicly funded, right? So patients can have extended health and they'll cover it. But let's say for a surgery, it's a very finite number of sessions that patients are offered that's funded. And then they're kind of on their own. I think this is because it's a 3-year program. It is different. I think the other conversation that's happening is that where should this be delivered? Like, is this a more of a community primary care type intervention, really, because it's for many years? Or is this something that should be a cancer center delivered program, even if it's virtually, delivered for patients who can't attend? I think those are logistics that are being sorted out. But hands down, it's whichever framework you come up with, it's a fraction of the cost of a lot of the things we do for this magnitude of benefit. Like from a cost effectiveness point of view, this is like a no-brainer. And then the other thing is that we know that in the community, there are physiotherapists or cancer rehab specialists who are kind of in the community, and we probably need to do a better job of identifying what are those clinics and programs. And many patients do have extended health. There's no reason why we can't start for whomever it's accessible, start being able offering this to them while we figure out a public mechanism to fund it.
So I guess based on that, what are your hopes and call to action for policymakers, for clinicians, for the public with regards to having, because we always want to say, okay, you have such great data that's now come out, but you want to ensure that if you implement a program that there is long-term sustainability.
Right.
So what's your call to action for policy?
So I think that we've historically thought about exercise as a survivorship, nice to have. The challenge trial has demonstrated that exercise is a treatment, right? That exercise improves survival. And with that, so then we have to treat it like an active treatment, right? And so that requires the same kind of commitment that we have for a radiation treatment or a surgical treatment or a chemotherapy or targeted treatment, is that we need to have it covered. We need to have the infrastructure to deliver it. We need to make it accessible. We need to build capacity for the people who are going to deliver it to be able to deliver it. And I think, unfortunately, especially in public systems which are resource constrained, I think, and as we think about, what's happening in the world and austerity and things like that, the survivorship stuff that suffers. It's this, that like everyone thinks, well, that's not as essential as surgery, radiation, chemo.
Right.
But now we're saying in this setting, it is. It's, and the magnitude of benefit is comparable to what we see with other approved treatments. So the call to action is that we need to embed this as like a pillar of a patient's treatment journey. And people want to, like, I think it's just a mechanism. There's no one I've talked to or Chris has talked to or Carrie's talked to who says, oh, well, we don't want to do that. It's just kind of like, well, we have to figure out how to do it. And that's actually encouraging to me because we will figure out the how. Yeah.
But shouldn't it be integrated into the multidisciplinary team that's making the decision on behalf of the patient within the institution, that this is like palliative care? The earlier you bring palliative care in that
Yeah.
early setting, this should be, now you're bringing in physiotherapy or physical activity into the process for a better outcome in the patient.
Yeah. I think that even though it took a long time to accrue to the study, we are now trying to create a sense of urgency around, okay, now we know. And I think what's slightly different about this is that there are amazingly brilliant, like, kinesiologists and physical activity consultants who know how to deliver this. Like, I might be a medical oncologist who likes to go for a run, but I cannot. I don't know how to deliver this program. So building the capacity for cancer rehab, I think, is really important. Like in most centers, including our own, we have that as part of a symptom management supportive care. And so it's resourced in a very different way. And I think what's kind of happened here, and this happened through the trial, and we see this with other trials, is that conducting the trial itself helped build capacity, because I was alluding to the fact earlier that for us to activate sites, they needed to onboard their local physical activity consultants, figure out a framework of how this is going to be delivered. And so now we're leveraging those connections to say, okay, now we want to implement this, and what does that look like? So I tend to be a very cup half full optimistic kind of person.
Yeah.
It may not, it's not going to happen overnight. Nothing happens overnight. But like I said, I think patients are motivated by the data. I think providers are motivated by the data, and payers we speak to want to be able to do this. It's so good. Like, the optics are good. Everything about it is good. So like I said, we'll see nothing, this will take work, and it will take advocacy, and it will take dissemination of the data. So grateful to both of you for allowing us to kind of talk about this on your podcast, but it'll happen.
Also, the other question I had was, this was specific for colon patients. That was, can you translate, or would you say, could you translate this to other tumor types, both solid tumors and liquid tumors?
Yeah, I know. I think we don't. I think, even can we translate it to other settings in colorectal cancer, like the advanced setting versus the adjuvant setting? I think it's going to be intuitive that people are going to want to extrapolate. Like, is there something about what we've talked about in terms of the biologic rationale for exercise improving cancer outcomes that's unique to colon cancer? Probably not, right? Probably not. And so wanting to extrapolate that to other solid tumors, we also know there has been retrospective data in lung cancer and breast cancer that has also shown that patients who are more physically active do better. So I think there will be that extrapolation that'll happen. But I think from an implementation piece, we're trying to focus on where the level 1 evidence is first. And once you build the capacity, then wouldn't it be great if we could say, well, why wouldn't we offer this for patients in the adjuvant breast setting or adjuvant lung setting? So, but I think that's going to be more downstream. And I don't think there's going to be another randomized trial for breast or a randomized trial for lung.
So you have 55 sites in this study and globally, right?
Yeah.
So they've all got multidisciplinary teams. They've all got speakers. Each of those was a PI for the study.
Yeah.
If this was a pharmaceutical agent, it would be classed as practice changing.
Mm-hmm.
Yeah.
Yes. Absolutely.
It would be shouted from publications everywhere, and it could happen overnight, right?
Yeah.
And the curves are even better than what you see in some of the pharmaceutical trials. How do you get those 55 people together to shout this out?
Yeah.
Okay.
Well,
It's Canada, US. I mean, sorry, John, you make a really great point. You have Canada, you have the UK, you have Australia.
right.
Over 800 patients, right, that were
Yeah.
part of this. So, John, great point.
Yeah.
Globally, how do you get all of these that's collaboration together? Shout it out.
I think it's not a lack of motivation. Like the investigators who chose to participate in the study, did it on shoestring budgets, did it securing grants to try to do this was not a trial where someone came to them and said, "Hey, here's your per case funding and this is what we're going to do." Which just speaks to the passion with which people really felt that this was important, that they were going to like really struggle to make it happen in their centers. And so that motivation is high. I think in terms of like if you think about, even like you said, if this was a drug, let's say, but if it was like a targeted treatment, then you still need to build the capacity to do the biomarker testing. Like, to give the analogy, like there's always a runway that is needed. In many respects, this is easier. Like the next day, I'm telling my patients, this is what you need to do. Like, just start, just start walking 3 hours a week. And this is what this looks like. So I think the passion with which we convey that message to patients versus the usual kind of like, oh yeah, that's what you should do, eat well and exercise, that it makes a difference. And so that should be today. That's a today thing. We should be strongly recommending to patients, if patients have access and ability to, have go to a cancer rehab specialist or go to get a personal trainer, whatever that might be, then there's a proportion of people who can do that right now. I think what we are mindful of is we need to focus on those people who wouldn't normally have that opportunity.
Yeah.
And so want to make sure we're pushing that agenda forward, that this has to be a universally accessible and equitable program. That's not, if you live in a small community that's 2 hours from Whitehorse, what does that look like? So then we have to have a virtual program. So we're having those discussions. I can only speak to within our province with our physical activity lead for the challenge study. And, Kristen Campbell, she's amazing. She's like, we should bring her on a podcast. And so she's all over it with our cancer rehab lead, like proposal, how we're going to do this, how we're going to deliver it remotely. This is the 5-year plan. And so, like I said, I think people who are involved with this are super passionate about it. And when like the data was positive, we were like just beyond the moon. Like
Absolutely.
it was just so great to be able to say now we can kind of, demonstrate this. As a sidebar, it's interesting. Like the data came out, ASCO was early June, and May in BC was the Workout to Conquer Cancer Month, where it's a foundation fundraiser. You work out every day. And I remember saying, I was like participating in that every day. And then when
Saw that.
yeah, we had the publication, I'm like, actually, now we can say working out really does conquer cancer. It's not just a catchy title. I think that's the gratifying piece. So to your point, John, yeah, there's an army of people who are involved with the trial who are really passionate about making it happen. It doesn't have the influence, I guess, of a big pharma company in terms of being able to change that overnight, if you will. But I don't think this is going to be something that people are just going to say, "Oh, that was nice," and move on from.
The other thing that got me excited is that you don't have to buy equipment, right? The only thing that we found out from our episode that we talked about yesterday, which was on knee replacement, is that you need a really good pair of walking shoes that you need to change out every 6 months. That's the cost. The
Yeah.
cost is your time and a pair of good walking shoes.
Yeah.
That would make our orthopedic friends that we met on the podcast, for the listeners
Yeah.
yesterday.
I think for the self-initiated and motivated patient who is ready to make that change, that's all that's involved. Is really some guidance, like there's brochure manuals on what that program was like. But for many people, they need that. Coming back to this point about behavioral change, they need that structured, and they need that counseling, and they need that support to be able to sustain this as a lifestyle, truly long-term lifestyle change.
I think you should get the chart that you had from the trial.
Yes.
That would be brilliant to just hand that out, because it simplifies the whole process.
Yeah.
Talks about the trial, the structure, the people that were in it, and what they actually did. It was just a nice little.
Yeah.
And
And just, again, a shout out to Dr. Cornea, who's the physical activity lead. Like, that's a lot of the work they're working on now is, they're the experts in framing how that should be presented to the public and what that looks like. So they are kind of working on how to message that and, create a program that can be readily given to patients.
so before we ask you for your 3 key takeaways, because John and I always ask our guests to provide 3 key takeaways. I think my key takeaway is when you're writing that prescription for that patient to say, you now require X therapy, beneath that should be plus exercise, a structured exercise program.
So my 3 key takeaways. So I might frame it as like, so takeaway for patients, takeaway for providers, and takeaway for payers.
Absolutely.
So my key takeaway for patients is that and this is going to be a bit of a background here, but often for patients, what's hard is the lack of control. And I feel like this is the most empowering intervention ever, because for patients, I would say this is something that is totally in your control. Like, you can do something that will improve your chances of survival in the long run. So for patients, I would be like, take control. Like, this is for providers, I would be, let's not, we are all busy. Like, there's like 10 different things in clinic that we're having to try to address with patients. And this needs to be one of those top 10 priorities. And sometimes we think about a discussion around lifestyle as kind of if we have time. So for providers, I would prioritize that this is something we should be talking about at the beginning. Like, even when we start adjuvant chemo, we should be saying, you know what, this is something that we need to embed as part of your routine moving forward. And then for payers, I think we already spoke to it. They need to step up. Like, payers need to say, look, this meets all the benchmarks. Improved survival, it's cost effective, high value, societal benefit. Like, need I say more?
Mic drop. John, I think we have the title for this upcoming episode. Take control, prioritize, step up.
Like it.
It would
I
go
like
really
it.
well. It's an amazing study.
Yeah.
I'm just blown away. Just
Oh, thank you. Yeah.
when I saw the survival curves, and that's maybe my question for you to close out for these patients. Different specialists talk about the survival curve. Each of them have got a different meaning for it, but this curve is different because it's based on exercise. And so if you could talk about the Kaplan-Meier curve and what it means, because patients aren't going to see this curve on this podcast. The visual part of it, when I saw them, I was just like,
Yeah.
whoa,
So,
it was a whoa thing.
yeah, I think so. For those of listeners who may not be familiar with what we're talking about for a Kaplan-Meier curve. So in the statistical analysis of what we call time to event endpoints, so time to recurrence or time to death, the typical comparison that's done is you follow patients until they have an event. And if they
Can you explain what an event is?
So event is defined by the endpoint. So for disease-free survival, an event was a recurrence or a new cancer a new cancer diagnosis or death. So usually death of any cause. In overall survival, it's just death of any cause. So sometimes the reason they're separated is because sometimes, you might be able to show an improvement in disease-free survival, but you may not see that difference in overall survival. And sometimes that is combination of, was the follow-up long enough? Was the difference enough that it actually drove survival? And to be fair, in most settings, in the adjuvant setting of colon cancer, disease-free survival is accepted as a surrogate for overall survival. But basically, you're following patients until they have an event. And on the Kaplan-Meier curve, so everyone starts at 100, right? Because they're like on the y-axis, because they're event-free. And then as an event happens, the curve will drop, right? Because like once an event happens, that patient comes off for follow-up. And then the patients remaining are those who are still free of an event. And so what you're referring to, John, is that as time passes, you start to see the curves separate, meaning more events happening in the control arm versus the exercise arm. And the wider the separation that we say, that's kind of like the greater that magnitude of benefit, that delta. And then you kind of, because you're following it over time. In this case, it was like 5, 8, 10 years of follow-up. You see, is that sustained over time?
Right.
And so for the disease-free survival, like you pointed out earlier, early you started to see a difference, like, reduced recurrences, we're seeing early within the first year. And they start to separate. And then the separation gets more and more over time. And for overall survival, because that's an endpoint of a death, the curves start off close, but then they really start to separate with enough maturity. Those patients whose the average age when patients were enrolled was 60. So, as they're getting older or they're having more events or their cancer recurred, but now they have died of their disease, you start to see that separation of the curves. And so we often refer to, like, sometimes something might be statistically significant, and I'm squinting, but your listeners can't see that. But you can't see, the curve is like, okay, I get that it's statistically significant, but it's such a small, difference. Like, so we say, is that really clinically meaningful? But when you have statistical significance and you see, like, I can see that difference on that curve, like there's a separation there. We say that is meaningful, right? And so that's probably more than people want to hear about Kaplan-Meier.
No, but I think they should understand in the pharmaceutical world, that's a regulatory endpoint globally with every country in the world.
Yeah.
For the approval of drugs, pharmaceutical agents, right, is to get disease-free survival. And the big thing is overall survival. So it
To
gets
be able
back
to
to
get
where
both, yeah.
to get both is an amazing outcome.
Yeah.
And to get that sustained response, and plus
8 years.
right, and over to 10 years, and then you have, like, to your point, that gap. We say you can drive a truck through it. Like, I mean, that is really significant.
Yeah. Yeah. And I think, this trial was really a good example of sort of tenacity and perseverance, especially by the leads, like by Carrie Cornea and Chris Booth, and also the CCTG and our GI disease site. Like, there was such a commitment that we're like, now we've started this, and we have to see it through. So again, coming back to just really gratifying to see that this has led to an outcome that will really, hopefully, that will I'm not going to forget the hope that will change the way in which we treat patients with colon cancer. So it's super exciting.
Yeah.
What a way to finish.
And you're right. Should have been ASCO plenary.
don't
I've said it. John, it's out there.
Yeah. Yeah. Should have been.
General. Yeah.
All right.
But, well, it's amazing, Charlene. And if the listeners could see your face on this on this episode,
I'm like,
they would really see the passion, the drive, the patient care. It's amazing, and what you've done for patients is just crazy. This is an amazing outcome.
Yeah.
For patients.
Yeah, that's super kind. And again, it's a group. It was the group, really.
Thank you,
I'm grateful for the opportunity to kind of share their success and talk about it.
Thanks, Sharlene, as always, for your time. This has been, it's John, we're having a lot of really fun episodes. I'm grateful. I'm so grateful. So we're blessed that we have such amazing guests. We have fantastic topics. So,
Okay.
Sharlene, congratulations to you and the challenge team again.
Thank you.
And we look forward to inviting you back for some other episodes to be determined on topics. lots of fun
Yeah.
topics we can discuss.
Sounds good. Sounds
Yeah.
good.
All right.
Okay.
Thanks, John.
Good.
Ciao.
Thank
Thanks,
you.
Zara. Thanks, Charlene. It's been a blessing.
Thanks so much.
Blessing
It's
to
very
meet you.
kind. Yeah.
Thank you very
Thank
much.
you. Thank you for the opportunity. Thanks.
Bye.
Bye.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.